Good morning, good afternoon, and good evening, everyone, and welcome to this Insights Scientific webinar titled Microvascular and Functional Ultrasound Imaging, Insights into Stroke and Neurovascular Diseases. I'm Andrew Davies from the events team here at Scientist.com, and I'll be your host today. This webinar has been sponsored by Iconius, so a big thank you to them for helping to make this event possible. We're very fortunate to have Professors Frank Lebrin and Denis Vivien with us today, who will discuss in vivo imaging, including functional ultrasound, and its application to the study of neurological conditions such as cerebral, hereditary angiopathies, and stroke. Thank you so much for joining us today, Frank. The floor is yours whenever you're ready.
Okay, so thanks for your kind introduction, Andrew. I will present some recent data showing how functional ultrasound imaging could bring important insights into a neurovascular disease, and importantly, how it could help identifying early markers of disease progression. As you may know, many neurovascular diseases are actually associated with early capillary defects. And if you want to develop therapies based on restoring, preventing early vascular anomalies to delay late brain damage, you need to identify early marker. And this is, I think, one of the major challenges in neuroimaging today in clinic. So after a short introduction about the macrovasculature, I will focus my presentation on a rare genetic vascular disease named hereditary hemorrhagic telangiectasia, and the use of functional ultrasound imaging and ultrasound localization microscopy to study HHT. So first, what is the macrovasculature? We define the macrovasculature as blood vessels with diameter ranging from 3 micrometer to 7 micrometer for capillaries, to blood vessels that are less than 100 micrometer. As you know, the cardiovascular system is the first organ that developed during embryonic development. It forms a well-organized network of tubes that is highly conserved between species. In the image on the left side, showing a mouse retinal vasculature, we can see that the vascular network is composed of artery, blood capillaries that form a dense network of blood vessels that contact almost each cell of the organ to deliver oxygen and nutrients, and family of veins. The blood vessels are composed of endothelial cells that are in blue, that form the inner lining of the vascular walls, and of neural cells called vascular smooth muscle cells that are in green in the image, and on pericytes in red. Interestingly, as you can see in the middle panel, along the arterial capillary vein axis, not only endothelial cells express different markers that reflect specific functions, but neural cells as well are different. At the arterial side, blood vessels are covered by vascular smooth muscle cells that are circumferentially aligned with cells that are perpendicular to the blood flow. If you go at the precapillary arteriole to the transition to the capillary bed, you can find unshading pericyte and mesh pericyte that strongly unwrap blood vessels. These vessels are important for the regulation of blood flow. Then you can find thin-strand pericyte in capillaries that form long processes that you can see in the image. And at the venular side, you have smooth muscle cells that have a stellate morphology. These vessels are important for permeability to immune cells and molecules. Many challenges remain if you want to study the macrovasculature. This is due to either the spatial resolution and sensitivity of the clinical neuroimaging modalities, or due to the need of preclinical invasive techniques and the use of photonic imaging that has limitations due to problems of tissue penetration. But however, the macrovasculature also offers some advantages. It is a highly conserved system between species, between human and mice, for example, and whereas mouse models are widely used to study human cardiovascular disease, as we can easily manipulate their genome, in many cases we can question the relevance of such models to study disease. And for example, if you look at the heart of the human on the mouse, you can see it beat very differently. In a male, you can see in the human, you can see 60 to 80 beats per minute, whereas in mice, you can see 350 to 700 beats per minute. The size is different, but also the rate of beating. If you look at the big vessel, you can see also that the diameter are largely different. And it's not only the size that is different, but also their composition. You have much more layer of smooth muscle cells in big vessels of human compared to mice. But now, if you go back to very small vessel, the capillary diameter, you can see at that stage between species, there is not much differences. And this can be explained because of the fact that these small vessels are really important to deliver oxygen and nutrients, and the blood flow rate has to stay almost at the same speed, 0.5 to 1.2 millimeter per second. And the role there is very simple. It's just to adapt to the tissue demand. So the tissue demands mainly in the brain, we call this function of hyperemia. When the neuron is activated, you need more oxygen. And then the capillaries, they just increase in diameter to increase their blood flow and provide more oxygen. You can measure that by ultrasound. So it is therefore not very surprising that many vascular or many diseases are associated with vascular defects. And along this kidney, lungs, heart, retina, brain axis, where you have a lot of capillaries with pericytes, very the organs with a much higher number of pericytes, you have a lot of different diseases that are associated with that organs. And for example, in the brain, I mean, there is definitely a role of the vascular network for Alzheimer's disease, vascular dementia, Parkinson's disease, stroke, epilepsy, spinal cord injury, multiple sclerosis, amyotrophic lateral sclerosis, radiation necrosis. Interestingly, there is also genetic vascular condition with vascular defect. And this is very interesting if you want to study a drug effect, because there you have the possibility to develop models with genetic mutation that are very close to human situation, but you have also the possibility to get a population of patients that is very defined for a trial. So many different diseases, but if you look carefully, they have the same underlying mechanism, and this is loss of vascular integrity. So what is loss of vascular integrity in the brain, for example? Most of the time it's endothelial cell dysfunction that are associated with a loss of endothelial cell-pericyte interaction and a loss of endothelial cell-cell junction, so communication. And that gives rise to a destabilization of the macrovasculature. As consequences, what you get is hypoperfusion, leakage and inflammation, pathological angiogenesis, capillary rarefaction, so loss of capillaries, right? And the development of vascular malformation. And at the end, you get irreversible tissue damage. So our strategy in our group is actually to develop drugs stabilizing the macrovasculature to prevent brain damage. And we got proof of concept long time ago on a genetic vascular disorder called hereditary hemorrhagic telangiectasia. So what is HHT? So HHT mostly affects 1 in 5,000 people worldwide, and this is due to mutations in two main genes that are endoglin, ENG, or LCVL1, ALK1 gene. The clinical symptoms of that vascular disorder are small and the development of small or large arteriovenous malformation, which are associated with recurrent and severe bleeding. These patients, they also develop migraine, and you can find edema in the brain, actually. When we call about severe bleeding, they can lose more than 1 liter of blood in noise, right? And they need transfusion. What is the cause of the disorder except the mutation? The mutation affects endothelial cells, but the consequences are poor neural cell attachment to the blood vessels that are prone to overgrowth, so excessive angiogenesis in response to angiogenic and inflammatory triggers. And what we have demonstrated is when we use a drug called thalidomide and its FDA-approved immunomodulatory immune drugs analogs, which are pomalidomide mostly, we can see that these drugs that are actually used to treat multiple myeloma, they have been shown to actually exert direct anti-myeloma effect, anti-inflammatory, anti-angiogenic, immunomodulatory properties. And what we found in the lab, they have also the ability to promote the interaction between endothelial cell and pericyte. And this is shown on the left part of the slide, when we use actually the retinal model of control animal and HHT, and what we did actually is electrophysiology on ex vivo retinas. So what you do, an electrical stimulation, you raise the calcium concentration in neural cells, and that gives rise to neural cell contraction and vessel constriction. And if you detect actually the intensity needed to provide this constriction, you can see whether or not you have a defect in this mouse model. And what we found mostly is like you need a higher current to actually provide constriction of the vessel, indicating that these neural cells are detached in this mouse model of HHT. When you treat the mice with thalidomide and then you look at the ability of parasite to induce constriction, we can see that thalidomide was able to rescue this parasite defect in this animal model. Interestingly, we also found that thalidomide inhibited angiogenesis and prevented the formation of arterial malformation in HHT retina. So this is shown in the right part of the slide, where actually in the HHT mouse model, you can see very nice arterial venous malformation. So it's a direct connection between the vein and the artery. And actually, when you treat a mouse with thalidomide, you can prevent the formation of AVN. More than 60 patients with HHT have received thalidomide in Europe for a mean of about 13 months. And what we found, actually, it was effective to prevent no reason gastrointestinal bleeding in these patients. It was effective to raise the hemoglobin levels. Unfortunately, it had side effects, and patients had to stop the treatment because of the development of peripheral neuropathy. There is today a clinical trial ongoing using pomalidomide, and in the lab, we are developing safer analogs retaining blood vessel stabilization properties. What I want to show, we have also demonstrated, and this is on the right side, that actually the patient that were treated with thalidomide, we did show an increased coverage of neural cells of the blood vessels, confirming that thalidomide also in women can actually increase vessel stabilization. Many publications have also reported that thalidomide and its analogs have benefit to treat neurological disease in preclinical models. Clinical implementation of safer analogs could therefore be a promising approach. Also, their implementation in clinical practice is limited by the lack of early marker of disease progression and a clear mechanism of actions. This is our main objective, focusing on the vessel angle. And for this, we are evaluating whether ultrasound imaging could provide useful modalities to study cerebral small-sized blood vessel disease and drug action, focusing on ultrasound localization macroscopy and functional ultrasound imaging. So what is ultrasound localization macroscopy? To look at the macroangiography. So it's a similar approach to actually photoactivatable localization macroscopy, PALM, and stochastic optical reconstruction microscopy, STORM, which are optic imaging. These methods rely on the activation of present localization of individual photo-switchable fluorophores to provide sub-diffraction resolution, improving spatial resolution by an order of magnitude. So what we do with UL, we just inject contrast agent, the macrobubble, and this macrobubble, we can actually individually identify them. And this is shown in the Eiffel Tower pictures, when you can see in the left side, you can see when you look at in the direct imaging. But now, if you point to each macrobubble, you can actually record a long time, and after reconstruct an image, and at the end get on the right side a very nice resolution imaging. So this is how we do it. For this, we use actually two approaches. So first, the macrobubble were injected with the Sonoview macrobubbles, and we did either through a bolus intravenously injected, so 50 macroliter with a concentration of 100 million macrobubble per ml, or either we use by infused intravenous injection of macrobubble using a pump with a speed of 13 microliter per minute. And the concentration of the macrobubbles were 200 million macrobubble per ml. So in one case, what you can actually evaluate nicely is like with the bolus, you get actually a high peak, but it decreases very quickly, right? Whereas in the second condition, I mean, the macrobubble concentration in the blood system was quite constant. And as you need to do a quite long acquisition, we did prefer to actually the second method to maintain high concentration of macrobubble the time we did actually make the acquisition of the images. In the middle panel, what you got is actually the 4 different plans of the control brain in the mice. You can see the nice resolution. And on the right panel is a control on HHT mice with a high resolution. There was no differences between control and HHT mice that was expected. But what we could actually detect is that the resolution of the vessel we were able to look at using ULM was between 15 to 40 micrometer, which is good enough if you want to study actually arteriovenous malformation. And it's just an example, just on the bottom side to the right. If you actually stimulate the brain with an angiogenic factor like vascular endothelial growth factor, you get this huge, massive AVM formation in blue. So we are actually sure that with using ULM, we can actually study AVM formation in mice. We next used functional ultrasound imaging to evaluate whether we could detect macrovascular dysfunction in HHT mice. So really at the macrovascular level, right, the capillary level. So compared to conventional ultrasound that use a focus beam over each line on an image, limiting the frame rate, ultra-fast ultrasound imaging uses an in-focus wave that is emitted to the tissue and echoes from individual scatterers are created by multiple channels in one go. This increases the Doppler sensitivity by 100-fold, and you can detect blood flow at velocity down to 1 millimeter per second, which is at the capillary level. You have a high spatial resolution, and you can detect hemodynamic changes. So first what we did actually identify how mutation in HHT that are found only in endothelial cells could affect the different population of neural cells along the arteriovenous axis. So for this, we use mouse models that are labeled in green for the arterial system, and we use also mouse models that have pericyte labeled in red. In red. And then we actually use the neural cell morphology as a marker of identification, and also the electrophysiology to study the function. And as you can see in the right side, you can see the smooth muscle cells were not affected by HHT mutation, whereas the un-HT pericyte EP or mesh pericyte MP were affected. And this is shown by a need of a higher current intensity to induce a vascular constriction, as previously shown. So it's very interesting that the smooth muscle cells and the pericyte were differently affected by the mutation. So what we did next, actually, to study hyperemia using FUS, so functional ultrasound imaging. So on the left side, just the summary of what we did. Actually, we use a whisker stimulation that increase the activity of the neuron and the need of oxygen, right? So when we actually injected the mice with ketamine and medetomidine as an anesthetic, and then we actually stimulated the whisker at different times. So either 10 seconds, 30 seconds. So what you see in the right, you see in the blue curve, the 10-second stimulation, in the black, the 30-second stimulation. So immediately you can see that there is a difference in terms of signal, due of course to the time, but also that the higher activity is found in the first 10 seconds, and then there is a slight decrease in blood volume, right? So meaning that a change in activity on the response. So you really have to define which time of stimulation you do when you want to study a mouse model. Then we have analyzed different plans on the brain along the somatosensorial cortex when the whisker stimulates the neuron, and we found that actually there is a kind of similar responses for over 600 micrometer on the brain slice. So meaning that we have, we are not the probe exactly on the same place, the probe having 200 micrometer right size, we still can have the same response, right? Quite important because at that time we didn't have the GPS system to actually make sure we are exactly all on the same plane when we do study the different mice. That was quite good to know. And then this is just a slide to show you how robust functional ultrasound imaging is. So on the left part, you can see that what we did is a 10 stimulation of 10 seconds, right, with 50-second rest. This is in red. And you can see also in the brain the location when there is a stimulation, because there is also a square and also a red spot, which is where actually you have an increase in blood volume. And then you can see this is the results of 10 mice, 10 control mice, with the dots showing one peak of stimulation. And now this intra-variability for one experiment is quite good. And the inter-variability between mice, when you can see there is no much difference in response between 10 different control mice. So this is just to demonstrate how the system is robust to study hyperemia. So then we compare control and HHT mice. And in the middle panel, you have the result of the accumulation of 10 pits of different mice. And then you can see the two curves, the black and the orange one. So the control is the black and the orange is the HHT. And then what we learn from the FUS is like HHT is defective in the ability to respond to hyperemia. So with curve stimulation, and there is two main effects. The first one is like there is a slight decrease in the higher stimulation rate, right? So there is a lower level of cerebral blood volume they can detect. But the most interesting thing, there is also a delay in the response. So you need more time to raise the highest response, right? That's quite interesting to look at this. So this proves that actually functional ultrasound imaging is sensitive enough to detect defect, even if we have only a small population of pericytes that are affected. So finally, we have tested if functional ultrasound imaging could be useful to actually monitor drug effect. So we use a drug promoting blood vessel stabilization. I cannot give you the name because of the intellectual property problem, but this one is one of the analog we have developed. And we have just tested the effect of that drug on pericyte using the electrophysiological system, electrical stimulation of pericyte in control HHT mice and HHT mice treated with our drug. And what we found, the drug was able to actually rescue the pericyte defect in animal, as the intensity of current used to stimulate vessel constriction was similar in controls. Then we did a FUS analysis, and we can see that if you treat HHT mice with a drug, actually the blue line is perfectly similar to control. So we could rescue the functional response as measured by ultrasound imaging. So as conclusion, we could say that ultrasound localization and macroscopy provide a unique imaging tool to study the architecture of the vascular malformation and possibly to get access to high blood flow measurements. We didn't do that yet. Functional ultrasound is sensitive enough to monitor early functional small-sized blood vessel anomalies. And we can also compare that response to what we see at the cell level using different technology like the electrophysiology. FUS is sensitive enough to monitor drug stabilizing blood vessels. And I think we believe that we can possibly translate our finding to clinical application. This is what we will do in the next few years in HHT patients.
Thank you, Frank, for that wonderful presentation. It is my pleasure to now welcome Denis Vivien, and thank you very much for joining us today, Denis. Take it away whenever you're ready.
Okay, so thank you to Iconeus for the invitation to show you a set of data that we got in my group about experimental stroke model. And we are talking from diagnosis to treatment and using different modalities of in vivo brain imaging, including fast ultrasound imaging. So all the data that I will show you today, that I will share with you, were obtained in my group. It's the INSERM Caen University group, which is named Physiopathology and Imaging of Neurological Disease, and we are located at the Blood and Brain at Caen Normandie Institute in Caen. So I will talk about stroke during my talk. So you should know that 1 of 6 people will suffer a stroke during a lifetime, and it is almost mentioned that there is one stroke occurring every 6 minutes in Europe, and also one patient, stroke patient, who will die every 14 minutes also in Europe. So which means that it's very important disease which need very important care to save a patient with a stroke. So some numbers about stroke. We should consider that it's 15 million stroke worldwide each year. And in France, it's 130,000 new cases of stroke every year. So there is two main types of stroke. So the first one are hemorrhagic stroke. It's around 15 to 20% of the stroke. And there are the consequences of aneurysm rupture, vertebral dissection, and any kind of vessel rupture inside of the brain. And there is also the ischemic stroke. It's 80% of the stroke. And there are the consequences of clots formation, either at the periphery and moving from the periphery to the brain, or directly formed inside of the brain. And there is different type of ischemic stroke. So today I will focus on ischemic stroke and I will not talk about hemorrhagic stroke. So if we look at the gold standard treatment right now for ischemic stroke, so the main drug treatment is the use of thrombolytics, which is named RTPA. So it's tissue type plasminogen activator. It's a protease which is used under its recombinant form to promote clot lysis and recanalization and reperfusion of the tissue. So the drug which is used is Actilis or alteplase. And there is some kind of limitation for the use of this thrombolytic with a short therapeutic window, which is around 4.5 hours after stroke onset, and recently extended to 6 hours, and in some countries 12 hours, when combined with thrombectomy. And thrombectomy, it's a mechanical removal, endovascular approaches to remove the clots. And usually the recommendation are to combine RTPA-induced thrombolysis with thrombectomy to improve recanalization and reperfusion of the tissue. It is important to know that the TPA, which is contained in Actilis, is also a natural molecule which is produced by endothelial cells and which is usually released into the circulation to activate plasminogen into plasmin and to promote clot lysis. But TPA is not only expressed by endothelial cells, you can see here, but it is also expressed by different brain cells, including neurons, glial cells, and also oligodendrocytes. So right now in my group, and I will just to sum up this kind of data because it's important for the rest of my presentation today. So is that TPA is more than a fibrinolytic, so which means that TPA is not only produced by the endothelial cells and released into circulation to control clot formation and clot lysis, but we also demonstrated that TPA is produced by neurons. And when neurons depolarize, they can release TPA at the synaptic cleft, and TPA at the same time of neurotransmitters such as glutamate can activate NMD receptor at the surface of neurons, promoting NMD receptor signaling. And in condition of brain injury, including stroke onset, this kind of interaction of TPA with NMD receptor mediates some kind of neurotoxicity, which is also named excitotoxicity. And we also demonstrated this last few years that TPA, the TPA produced by endothelial cells, when present into the circulation, can also interact and activate NMD receptor, which are expressed not in neurons, but in endothelial cells, and they are associated with tight junction proteins. And we demonstrated that the vascular TPA, by interacting with this kind of NMD receptor in endothelial cells, promote inflammatory processes, transmigration of inflammatory cells from the circulation to the brain tissue. So which means that we have at the end 3 main effects of TPA. One, which is clearly beneficial in the context of stroke, which is it's due to its fibrinolytic activity, promoting clot lysis, recanalization, and reperfusion of the tissue, and 2 deleterious effects. One is at the level of neurons by promoting neurotoxicity and neuronal cell death, and the second one at the level of the vessels, promoting inflammatory processes. So in this context, in my group, we have generated different molecular tools to prevent this two-sided deleterious effect of TPA. The first one is an antibody, it's a monoclonal antibody, which is named glunomab. And glunomab can completely block the interaction of TPA with an NMD receptor. And we demonstrated that this lysine in position 178 in the GluN1 subunit of an NMD receptor is critical to mediate this function of TPA and NMD receptor. And glunomab can bind this domain and prevent interaction of TPA with an NMD receptor. We also generated a mutant of TPA, which is named OpTPA. And this mutant of TPA contains some kind of point mutation, also preventing its interaction with NMD receptor. So there are right now 2 startups developing this drug for clinical application. Optolysis with a mutant of TPA for the drainage of the blood in the context of hemorrhagic stroke, and glunomab, which is developed by Therapeutic in the context of ischemic stroke to prevent these 2 deleterious effects of TPA without affecting its beneficial fibrinolytic activity. So this is important because I will use these different tools in animal models and in different models of thromboembolic stroke. So the origin of stroke in human is due to clots generated either at the periphery or inside of the brain, leading to occlusion of the brain vessel, especially the middle cerebral artery. So we decide to mimic this situation in animal models and especially in rodents, here in mice. And what we can do is to induce in situ clot formation. So basically here we use a seamless pipette that we can insert in the middle cerebral artery, and we can infuse thrombin. And thrombin is a protease which is involved at the origin of the cascade of thrombosis. And just the local injection of thrombin leads to a clot formation, in situ clot formation, mimicking the clinical situation. So we can sum up this thromboembolic stroke model in mice. So you can see here we have in situ clot formation. You can see by histology here the clot which is formed in the middle cerebral artery. We can also visualize what's happened at the vascular level by using angiography. It's MR angiography. It's looking inside of the brain using MRI. And you can see here that we have the middle cerebral artery and we have an occlusion of the middle cerebral artery. And interestingly, with this model, we can mimic the clinical care. We can use RTPA, so actilyse, and which we can use it to promote clot lysis, exactly what's happened in clinic. So you can see here that when we measure cerebral blood flow, as soon as we inject thrombin, we have a drop of the cerebral blood flow, and we can treat by TPA, 10% in bolus, 90% fusion, exactly as in clinic, to promote recanalization and reperfusion of the tissue. And this is also visible here when we look at the angiographic score. Interestingly, we can also follow the ischemic lesion, the brain lesion. So you can see here by ADC that we have a lesion which is restricted to the cortical area, which is the area in which the middle cerebral artery drives the blood. And you can also see here by MRI, it's the T2 MRI that we have a lesion, an ischemic lesion, which is also restricted to the cortical area. Interestingly, when we treat by the gold standard treatment in clinic TPA, you can see that we got a reduction of the lesion volume, so which means that TPA in this context is beneficial exactly also as in clinic. So using these different models, we decide to test different strategy to protect the brain. And the first strategy that we develop is the use of glunomab. So the antibody that I showed you before, we can block this interaction of TPA with NMD receptors. And interestingly, when we look at the lesion volume, so here it's a model of thromboembolic stroke that I showed you before. We treat with TPA IV 10 minutes after stroke onset, and we can look at the lesion volume by MRI at 24 hours. As expected, TPA alone is clearly beneficial, reducing the lesion volume. We can repeat the same experiment, but this time with TPA not 20 minutes after stroke onset, but 4 hours after stroke onset. And in this condition, although TPA promotes recanalization and reperfusion of the tissue, there is no reduction of the lesion volume, but an increase of the lesion volume. And this is explained by the deleterious effect that I showed you before, targeting neurons and also inflammatory processes. When we combine this TPA late with glunomab, you can see that we can rescue the beneficial effect of TPA alone. So which means that glunomab, by blocking the deleterious effect of TPA on NMD receptor, neuronal and endothelial cells, can rescue the only beneficial effect of RTPA-induced reperfusion with an improvement of the functional recovery and lesion volume. So we look at the functional recovery using this model. And here you can see that when we used glunomab here, and if we look at the neurological deficit, we have a clear beneficial effect when we evaluate this beneficial effect at 24 hours. And this beneficial effect is still there after 1 month and 3 months. So demonstrating that preventing the deleterious effect of TPA is clearly beneficial. But there is also a different situation in the context of ischemic stroke. It's not easy, as I showed you just before, because the efficacy of recanalization is very low in the clinical setting, with only 20% of recanalization for patients who are treated by RTPA-induced fibrinolysis. It is also important to know that, in fact, the efficacy of recanalization by TPA depends on the site of occlusion. And in fact, we have an efficacy of around 30% when the clot is located in the middle cerebral artery, M1 and M2 segments. But when the clot is located in the basal artery, in fact, the efficacy of recanalization is very low. So the efficacy of RTPA-mediated fibrinolysis thrombolysis is also dependent of the composition of the clot. When clots are rich in platelets, they become resistant to RTPA treatment. At the opposite, when clots are not rich in platelets, but rich in fibrin, so which means poor in platelets, we got an efficacy of around 30%. It is why it is right now the recommendation to combine fibrinolysis with thrombectomy, as I showed you before, to significantly improve the efficacy of recanalization. But this high efficacy of recanalization, 70 to 80%, is not directly correlated with a similar beneficial effect in terms of functional recovery. So which means that there is a need for additional treatment to fill out this gap between efficacy of recanalization and functional recovery. So it's exactly what we try to do in my group, and we try also to mimic this different clinical situation. So I show you before the thrombin model in which we can induce ischemic lesions which are located in the cortical area, and we can treat either with TPA early or late after stroke onset, with a beneficial effect when TPA is infused early after stroke onset, and deleterious effect when infused late after stroke onset. But we can also mimic different situation, which mean platelet-rich clot, and we can apply ferric chloride to the endothelium, also leading to ischemic lesion volume in the cortical area, but this time with clots containing high level of platelets. And in fact, this kind of clots are completely resistant to RTPA treatment, either early or late. We can evaluate this efficacy of treatment by looking at the angiographic score by MRI. In the context of thrombin, you can see that we have a clear efficacy of RTPA treatment, promoting recanalization of the tissue. And it is not the case when we have clots rich in platelets. We have no efficacy of RTPA treatment. And this can be also evaluated by using perfusion rate imaging using MRI. So right now we have these different models which are reproducing the clinical situation, and we decide, in addition of the use of glunomab to prevent the interaction of TPA with an NMD receptor, to use different strategy. And here I would like to show you the use of a drug which is targeting one component of the clot, which is a von Willebrand factor. And we demonstrated that N-acetylcysteine, which is contained in mucomist, but which is also contained in a drug which is named Idonac, which is used for the treatment of patients with paracetamol intoxication. In fact, we demonstrated that N-acetylcysteine can reduce von Willebrand factor and can thus disrupt clots formation, even when they are rich in von Willebrand factor and rich in platelets, promoting clot lysis and recanalization, reperfusion of the tissue. And this was tested in the different stroke models that I showed you before. So the thrombin model with platelets which are poor, with clots which are poor in platelet and rich in fibrin, ferric chloride with clots which are rich in platelet and resistant to TPA. And here it's an additional model with permanent occlusion of the middle cerebral artery. And we clearly demonstrated in this model, looking at the cerebral blood flow and lesion volumes, that N-acetylcysteine is highly beneficial, promoting clot lysis and recanalization and reperfusion of the tissue, leading to reduced lesion volume when used alone in a condition in which TPA or heparin or antibody targeting platelet GP2B3A or aspirin do not work. So we have right now different models of thromboemboli or different model of stroke in rodents in which we can test drugs which could be used in clinic. And the data that I showed you before using N-acetylcysteine leads to a set of data which allow us to start a clinical trial, which is named in the context of the RHU booster. It's N-acetylcysteine with IV thrombolysis in the context of acute ischemic stroke, and the clinical trial is ongoing, and we are doing right now the safety part of this clinical trial, and we expect to start very soon the efficacy part of these clinical trials. So, but in this context of stroke, so we have these different models. But what is very important is to improve the diagnosis and the prognosis of ischemic stroke. And it would be very important to determine, by using different imaging modalities, whether clots are rich in fibrin or rich in platelets, or whether they will be responsive to RTPA treatment or N-acetylcysteine treatment or glunomab treatment, and also to determine whether inflammation occurs. And this could be a way to propose therapies, including not only fibrinolytic treatment, but neuroprotective treatment and anti-inflammatory treatment. And here you can see that we can imagine a cohort of penguins at the arrival at the emergency unit. All of them have a stroke, but you cannot discriminate which one has clots which will be responsive to TPA, which one will need a thrombectomy combined to TPA, which one will need anti-inflammatory treatment or N-acetylcysteine or whatever. And it's what we try to develop in my group. And to do that, we develop different modalities of brain imaging, first using MRI. And we are very interested by inflammatory processes, and inflammatory cells which are in the circulation are well known to interact with the endothelium, so leading to endothelial cell activation. And this activation of endothelial cells is needed for the adhesion of inflammatory cells to the endothelium and transmigration of these inflammatory cells from the circulation to the brain parenchyma. And we know that this adhesion and transmigration is dependent of a set of molecules which are expressed at the surface of inflammatory cells, but which are also expressed at the surface of endothelial cells, and molecules such as P-selectin, ECAM1, VCAM1, which are named adhesion molecules. And what we did in my group, we have designed micro tool or nano tools which should allow to perform molecular in vivo brain imaging using MRI. And to do that, we use the paramagnetic beads here, which are MPEO, that we can link with antibodies targeting adhesion molecules, and here such as VCAM1. And you can see here that in mice, when we infuse TNF inside of the brain, we can induce inflammatory processes. And by using these VCAM1 paramagnetic beats, we can reveal in vivo the presence of these adhesion molecules at the surface of endothelial cells using MRI. So which means that we can use this methodology to predict inflammatory processes. And it's what we did in the context of the thromboembolic ischemic stroke that I showed you before. And as you can see here, so here you have the brain of the mice following ischemic lesion very early after stroke onset. And before injection of the paramagnetic beats, you can see anything. And interestingly, after injection of this paramagnetic beats targeting VCAM1, you can visualize here this EPO signal inside of the brain vessels, demonstrating the presence of endothelial activation of this VCAM1, which are the molecular events at the onset of inflammatory processes. And we demonstrated by using these methodologies that we can predict inflammatory processes. And we did this in vivo MR imaging, and we got a very nice correlation between this in vivo non-invasive imaging with control immunohistology. And you can see here the paramagnetic beats that I showed you before here, which are attached to VCAM1 positive vessels. So this means that right now we have an in vivo tool for diagnosis of inflammatory processes and endothelial activation. So in theory, it is possible to do this kind of molecular imaging for any kind of adhesion molecules. This could be P-selectin, MAdCAM1, and so on. It's exactly what we did. And I would like to show you here the same modalities of molecular imaging, but targeting not VCAM1, but P-selectin. And this is a context of a model of transient ischemic stroke in which you cannot visualize any ischemic lesion by regular MRI, but by using molecular imaging targeting P-selectin, you can see here that we have EPO signal, so which means the presence of P-selectin in brain vessels, and also with a perfect match with the control immunohistochemistry. So which means that we have right now a tool and molecular tools to improve the diagnosis of ischemic stroke, especially endothelial activation and inflammatory processes. We have also developed these modalities in model of inflammatory disease, such as multiple sclerosis, as I show you here, and it can also be performed for an additional adhesion molecule, MAdCAM, in the context of Crohn's disease for the intestine. So, but unfortunately, this kind of paramagnetic tools cannot be used in human because they are not biodegradable. And more recently, we have generated the same type of particles, microparticles, but they are made of a complex of polydopamine. And we demonstrated that these kind of particles are very useful and works very well. So you can see here, we can again detect inflammatory processes in vivo and with some kind of particles which could be used in clinic because they are completely biodegradable. And we show you this in the next slide. So here it's our particles that we call M3P looks like. They look like this kind of shape by using microscopy. And here it's all the particles looks like by using electron microscopy. We also demonstrated that they can be recaptured and phagocytosis by macrophages and degraded in macrophages. And we also demonstrated the biodistribution of these particles in vivo, either in the liver, the spleen, and the kidney. And we demonstrated that they display all the characteristics of biodegradable particles with no long-term accumulation in the liver, neither in the kidney, which means that it should be possible to use them for a clinical application, and we are working on this right now. We also demonstrated that this kind of particles could be used either in 7T MRI or 1.5T MRI, which means that they are not only usable for preclinical and research investigation, but they could be also used for clinical investigation at the hospital. So right now we have these new modalities that we name immunomagnetic resonance imaging for targeting inflammatory processes. So as I showed you before, it is important in the context of stroke, not only to determine whether we have a patient with an ischemic or hemorrhagic stroke, it is also important to determine the composition of the clots, whether clots are rich in fibrin and responsive to RTP treatment, rich in platelets and thus resistant to RTP treatment. It is also important to reveal inflammatory processes and show you that molecular MR imaging could be a way to address this issue, and which means that the future of stroke treatment should not be only one treatment or only one treatment combined with thrombectomy, but it could be a cocktail of treatment. And to do that and to improve the diagnosis of stroke patient and also the prognosis of stroke patient, we also develop a new modalities in collaboration with Michael Tanter in Paris, which is the use of fast ultrasound imaging for early diagnosis of stroke. And for this kind of experiment and data, we use exactly the same models that I showed you before, the thromboembolic stroke model, in which we can induce ischemic lesions that you can visualize here by MRI, and we used fast ultrasound imaging and plan a wave to reveal what's happened in terms of cerebral blood flow inside of the brain. And so the design of the experiment was to induce thromboembolic stroke model using thrombin, and then we decide either to treat with RTPA or no treatment. We look at what's happened in terms of lesion volume and cerebral blood flow very early after stroke onset, and also looking by MRI at 24 hours. And interestingly, what we can see is that by using a fast ultrasound imaging, we can reveal very early after stroke onset, which means few seconds, few minutes after stroke onset, we can visualize here the hypoperfusion of the tissue due to the clot formation. We can also evaluate the reperfusion here at 2 hours after stroke onset. And you can see that we have a reduction of the hypoperfused tissue. And interestingly, there is a strong correlation between what we can measure by using fast ultrasound imaging just after stroke onset and at 2 hours with the final lesion volume measured by MRI at 24 hours. And it is important to mention at this time that if we perform MRI at 2 hours or just after stroke onset, it will be not possible to see any kind of lesion of brain injury. So which means that fast ultrasound imaging, it's a very relevant strategy to evaluate what's occurred very early after stroke onset in terms of ischemic lesion volume. And this is data that we obtain. So again, it's thromboembolic stroke model, no treatment by TPA, just saline. And we look at the lesion, at the hypoperfusion at 2 hours and just after stroke onset, and also MRI at 24 hours. You can see here the map of hypoperfusion. You can see that we have clearly an hypoperfusion of the tissue just after stroke onset. We also look at what's happened at 2 hours, and there is no reperfusion of the tissue because there are no treatment by TPA, so the clots are still there. So we can evaluate very early after stroke onset treatment at 2 hours, we can evaluate the efficacy of recanalization, and you can see here that we have no recanalization and no reperfusion because no treatment. Interestingly, if we compare the hypoperfusion profile just after stroke onset and the hypoperfusion profile at 2 hours, we can see that it is exactly the same that the lesion volume measured at 24 hours by MRI. So which means that using fast ultrasound imaging, we are predictive of the final lesion volume, even when we look at this very early after stroke onset or just after starting a treatment. We also perform the same experiment, but this time with RTP treatment. So exactly the same design of experiment. So again, when we look at the hypoperfusion by using fast ultrasound imaging just after stroke onset, so you can see that we still have the hypoperfusion as expected, but when we treat by TPA, because we have RTPA sensitive clots, you can visualize here the reperfusion of the tissue. So which means that the animal here are responsive to the treatment because we have clots which are rich in fibrin and poor in platelets. again, very interesting. Sometimes which is very interesting. So we can look at the hypoperfusion profile just after stroke onset. And you can see here how the hypoperfused area looks like. When we treat by TPA, we can visualize very early after the beginning of the treatment, 2 hours after stroke onset. We can visualize the efficacy of the treatment with a huge reduction of the hypoperfused area. And interestingly, again, what we can measure by fast ultrasound imaging at 2 hours is correlated and is completely in agreement with a lesion volume measured by MRI at 24 hours. So, which means that here we are again predictive of the efficacy of the treatment and the response to treatment. So, which means that this kind of strategy could be very useful in clinic because right now we have no modalities to evaluate the response to treatment. And here, by using fast ultrasound imaging, it could be used at very early time after stroke onset, very early time after the beginning of the treatment, that the patient are responsive to the treatment and the thrombolytic strategy. So we can do a quantification of this modality of fast ultrasound imaging in the stroke model. So as you can see here, we can look at the volume of lesion measured by MRI at 24 hours. And we can look at the correlation with the hypoperfused tissue measured by fast ultrasound imaging just after stroke onset. And as expected, we have a strong correlation when we look at animals which are not treated by TPA. It's not correlated when animals will be treated by TPA, so which is highly relevant. And interestingly, when we do exactly the same correlation, MRI at 24 hours and hypoperfuse the volume at 2 hours by using fast ultrasound imaging, but this time at 2 hours, so which means after the beginning of hereditary treatment, we got a very nice correlation between this lesion volume at 24 hours and hypoperfused tissue. So which means that it would be a strategy, highly relevant methodology to predict response to treatment and also to predict recanalization and reperfusion of the tissue in stroke patient. It is also interesting to see that we can also establish a Tiki score, which is also a score which is used in clinic, which could predict the efficacy of recanalization and reperfusion of the tissue. It is also possible by using this methodology to determine a kinetic of reperfusion of the tissue. So which means that by using fast ultrasound imaging, we can address a different important issue for ischemic stroke, including prediction of response to treatment, efficacy of recanalization, efficacy of reperfusion, and this very early after stroke onset, which is not possible with current imaging modality at the hospital, especially CT scan and MRI. So to conclude, I would like to say that all the experiments that I show you today were performed in anesthetized animals. And you know that anesthesia play a very important role in the context of the physiopathology of ischemic stroke, and that stroke in human does not occur in a patient under anesthesia. So, which means that we should now move to a model of thromboembolic stroke and imaging modalities in awake mice. And it's exactly what we are doing. And right now we have a model of thromboembolic stroke performed in awake mice at the time of stroke onset. And also we can use fast ultrasound imaging in awake animals to look at tissue reperfusion and tissue recanalization. And in parallel, we can also perform MRI modalities in awake animals, not only looking at the lesion volume, molecular imaging that I showed you before for VCAM1, and also to look at cerebral blood flow by using arterial spin labeling. And this is experiments which are ongoing. So to finish, I would like to thank Iconeus for the invitation to give a talk today, and also to thank the people who are working in my group on these different modalities, especially Cyril Orsay for fast ultrasound imaging and Maxime Goberti for molecular imaging using MRI. Thank you for your attention.
All right. Thank you very much, Denis and Frank, for the wonderful presentations today. With that, let's move right on to the Q&A. If you have a question that you would like to ask, You can submit it using the Ask a Question panel shaking on the screen. And we may not have time to cover everything during the live session, but we'll be releasing a Q&A report within a few weeks, so stay tuned for that. And let's just bring Frank and Denny back on the line. Here we have a question for you, maybe to begin, Frank. How are you able to form the microfiber architecture image using FUS, and what model do you use of the fiber arrangement?
Oh, so that has been developed. I mean, that's a good question. Actually, we do that in collaboration with Michael Tonter's lab, and they have developed soft, so they track the macrobubble, right? And then they can make the right position. It's a 2D imaging, right, as far. So we don't have access to a 3D, but I know that they have developed a 3D probe. And so I don't have access directly to the soft, but I know that now it's developed by the Iconis system. So they have directly made that, right?
Okay, so wonderful. For Denny, a question here. For both of you, I suppose we could, maybe Frank, you can follow up afterwards. The question is, what are the possibilities of translation to the clinic of the methodologies that you've presented? For example, the molecular MR imaging and also the fast ultrasound imaging, specifically in the field of stroke.
Yeah, it's an interesting question. So about MR imaging for molecular imaging. So the first point is to have access to particles which are biodegradables and which could be used in human. So this, we are working on that right now. And we have a patent on particles which are now biodegradable and be useful and could be used in human. And it's just a paper which was accepted and which is come out in Science Advance in a couple of weeks from now. And also the second point is to have a good antibody for the target that you are looking for. So about the particles, it's almost done. And the second point is to get good antibodies which could bind to the target in human. And about fast ultrasound imaging, I think that something that we can go fast to clinic, and we have a clinical investigation ongoing in collaboration with one neurosurgeon, which is Thomas Gabriel, in your lab in Caen. And Thomas is looking for secondary ischemic lesion following intracerebral hemorrhages. And he's going to use fast ultrasound imaging to follow vasospasm and secondary brain injury. So I think that for fast ultrasound imaging, we are not so far of clinical application, and there is already a paper published, not by my group, by others, for its use in human. And for molecular imaging, it's not for tomorrow, but we think that there is good opportunities of translation to clinic in the future.
Wonderful. Did you want to elaborate on your own experiences as well, Frank, with the opportunities for translation from preclinical to clinical?
Yeah, so from our side, I think we are working on small vascular heart disease. So the first idea is like what we will do in the next few years is actually to use functional ultrasound imaging to monitor drug treatment. Starting with HHT. So we do believe that there is a lack of actually, let's say, possibility to actually monitor drug except the bleeding, which is just a survey. So the idea is using the imaging and starting with the patient as their own control before treatment and during treatment and after treatment during trial will help to see whether or not functional ultrasound would be sufficient enough to have access to these small size vessels, right? There is no imaging to do that these days. So that's our idea, actually, in all internal organs, starting with the brain. So we have actually a collaboration with Iconis and Michael Tonter to do that in the trial within the next 3 years.
All right. Well, wonderful. Maybe we'll see you here again with some updates on both of your work. A question for you, Denny, regarding the significance or the stroke model. And could you repeat the significance of the stroke model in awake mice? I'm not sure if they mean the statistical significance or just repeating the whole experiment So perhaps you could comment on that.
Okay, so in the literature there are a lot of stroke models available. Most of the stroke models used in preclinical right now in the literature are permanent occlusion of the middle cerebral artery, which is electrocoagulation of the middle cerebri. So this will never occur in human. And a model which is largely used also, it's occlusion by using a filament. It's endovascular approach. And then you can remove the filament. And people would say that it could mimic one of the clinical situation, so mimicking thrombectomy, so endovascular removal of the clot. But all of these models are not induced by in situ clot formation. It's what we developed in my group several years ago. And now we have models in which we can induce stroke by local clots formation, and we can monitor the composition of the clots, either rich in fibrin, so which means that they are these kind of clots are sensitive to the gold standard treatment RTPA, or rich in platelets, and they become resistant to TPA. So exactly mimicking the main clinical situation. So what I should add is that this last 10 years, 15 years, all the preclinical investigation which have suggested treatment for stroke using this preclinical model failed when they translate to clinic. So we hope that by using models which are more close to the clinical situation, so the ones that I just mentioned with the in situ clot formation, and also relevant modalities of brain imaging, MR and fast ultrasound imaging, should help to make the preclinical investigation more relevant with, we hope, successful translation to the clinical situation.
Wonderful. Maybe just I'm conscious of the time. We've gone a little bit over. Maybe if you could both finish off with some comments regarding, there's a great question here. What are in your opinion, the gaps to fill in prior to the translation to the clinic for fast ultrasound imaging? And maybe we can start with Frank and then finish off with Denny.
Well, I think the resolution is the key there. In preclinical models, of course, we can use the photonic imaging, and then we have access almost to the cell level, right? So we can really see what the consequences of cellular defect associated with vascular dysfunctions. As soon as you want to go for the clinic, then there's a true gap. So with a lot of preclinical study we do on drug assay we cannot translate this to the clinic because we don't have the readout. So I think with the ultrasound today, we will reach that level, right? Having access not only to, capillary level in terms of images, but also to their functionality. Then we might be able, to translate what within preclinical levels with drug treatment to the clinic.
All right, fantastic. And Denny, some final thoughts.
Yeah, I think that the main point for translation to clinic would be to convince clinicians that this technology could help them for diagnosis, prognosis, and thus to decide treatment. And I think most of the preclinical investigators are highly convinced about the relevance of this methodology. But to convince clinicians, I think it should be clearly demonstrated that the skull is not a problem, because there are still the idea that the skull is a limitation, and I know that it is not the case because there is clear data demonstrating that you can work through the skull. And the second main point for me is also to get images which could include the whole brain. Because at least for ischemic or hemorrhagic stroke, you don't know where the lesion is located or the clot is located, and by using CT scan or MRI, you can have access to the whole brain. And it is the main limitation. So if we convince clinicians that you can go through the skull and take skull, and that it would be possible to have a view on the whole brain, then it should be more easy to convince them to use this methodology, because it's less expensive, maybe more easy to use at the bedside than CT scan or MRI.
Okay, well, wonderful. I'd just like to thank you both for your wonderful presentations today and sharing your insights in the Q&A. It's been an absolute pleasure having you with us.
Okay, thank you for the invitation.
Thank you.
Thank you, Tony.
Bye.
Thank you, Frank. I'd really like to say a big thank you to everyone in the audience for participating here today. And last but not least, of course, we'd like to thank our sponsor, Iconius. So in closing, we hope you enjoyed this Inside Scientific webinar, and we hope to see you again next time. Thank you.